Okay, great, thanks. So good afternoon again. I'm Susan Olson. I'm the Chief Operating Officer of Edge Analytics. So leveraging human and artificial intelligence, Edge Analytics enables any company, regardless of their size or industry, to really transform their data into better business strategies and also optimize their decision making. So we're very excited to be at HEN today and launch our new healthcare product, Jump by Edge, which facilitates healthcare consumer outreach here at the HEN CONVERGE. So I'm really eager to hear from our expert panel today about United Community. So access to human services really affects community residents on many levels, from effectiveness of care to timeliness of care, and certainly even access to care. And so those impediments really often start outside of the scope of what we think of as care. Many people experience barriers to basic needs to food access, to financial resources, and housing. And so Metro United Way has launched the United Community platform really to aid individuals and families and to support organizations in reaching their desired outcomes for our community. So United Community is the first in the nation to join healthcare, community-based organizations, and education together all on one platform and reduce these barriers to access for the members of our community. So without further ado, to tell us more, please welcome Scott Bowers, Barbara Gordon, Stacy Sivak, and Teresa Reno-Weber.
Thank you so much, Susan, and thank you all for hanging in there and staying with us this afternoon. So I'm Teresa Reno-Weber, and I am the president and CEO of Metro United Way, and Susan did a great job introducing, I think, the overview of this panel, but some of you might be wondering, United Way, health, some may know the connections, some may not. And for United Way, we really have been focused on looking at the social determinants, and that's a new term for some, and for those of you in the healthcare space, it's not a surprising term. But United Way for over 100 years has been in our community and has been really focused on understanding how we help individuals get connected to the services that they need to truly thrive. And whatever those needs are, United Way has been in the space of connecting organizations across sectors, whether it be healthcare or education or social services, to be able to wrap around and meet the needs of individuals. And we're really excited that at this moment in time, we have the ability to really leapfrog forward with technology being where it's at, with our community and our partners being where they are at, to be able to truly provide the most effective, efficient, innovative care for individuals in our community. And that's what we're going to talk to you a little bit about today. But first, I would like our esteemed panel of folks here to introduce themselves, their role in the community, and just at a high level, their connection to this United Community effort, which we're going to go into a lot more detail for. So, Scott, I'm going to turn it to you first.
All right, don't turn the lava mic on, 'cause we'll have feedback and everybody will go running to the bar early. I'm Scott Bowers. I'm the CEO of Passport. She asked me to tell a little bit about myself. I got into Medicaid managed care about 22 years ago, right about the time that Passport Health Plan was getting into Medicaid managed care. So there's some irony there. I joined Passport in June. I'm thrilled to have joined a legacy of and a tradition of folks who are focused on innovation and collaboration. I've spent my career also focused on helping the vulnerable individuals and underserved populations break down barriers to get the care that they need in order to improve their quality of life and their wellness. So that's been my personal passion for 22 years, having started in Medicaid managed care back then. And Passport also has been going along that same path. So I really am proud to be here in Louisville since June and focused on advancing not just Louisville's health and well-being, but throughout the Commonwealth.
Good afternoon. I don't think mine's working either. Good afternoon. My name is Barbara Gordon, and I am the Director of Social Services at KIPTA. KIPTA stands for Kentuckiana Regional Planning and Development Agency. And in my role, I also lead our area agency on aging and independent living and the Aging and Disability Resource Center that serves Jefferson County, but also serves the 6 surrounding counties So we're a 7-county region. We literally serve birth to death in various capacities, but obviously have a really, really strong focus on serving older adults, their caregivers, as well as persons with disabilities. Our primary goal is to help people to stay in the community for as long as possible and to bring in the services and the care that they need to make sure they're able to do that. As I think someone said earlier today, the majority of our country, of citizens that live in this nation, want to live in the community, want to stay at home. And as most of us know, just from a public policy perspective, it is less expensive for us to help individuals to do that. But there are a lot of gaps in services, and often those gaps are there not necessarily because the services are not in the community, it's because people don't know about them or they can't access them. So I'm really excited about this particular initiative, and once I learned about it, I think I inserted myself a little bit to make sure that our agency could work with United Way in making sure that this particular initiative is advanced in a positive way.
I'm going to use this too. Hi, everyone. I'm Stacy Sivak. I am the Chief Revenue Officer at Unite Us. Unite Us is the technology referral platform that underpins the United Community Referral Network. We are both the technology platform, but we also have a team of on-the-ground experts that work with community-based organizations like Barbara's, bringing them together onto the network, socializing them to how to work and refer to each other in the community, train them, and really govern how a community-based referral network like this can be the most impactful. We're excited to talk to you all today, and I'm going to pass this back to you, Teresa.
Awesome, thank you guys. So clearly a phenomenal panel of individuals who are kind of coming at this effort from all different sides. And I do want to share that the United Community effort is not just about a technology, but it's also about working differently as a community. And so this effort was just launched in April, and it is not just United Ways, but we had a lot of phenomenal partners who'd been doing good work in our community for a number of years to try to figure out how to connect resources outside of the four walls of their own organization, but to other partners across the community. We heard from Humana earlier today and the Louisville Health Advisory Board, and for a long time there's been a community coordination of care group that have been trying to find a platform and a way to be able to connect the dots and to share information and referrals across our community. Similarly, in the education space, we know that children who are falling behind in school, it's many times not because of the academic aptitude, but it's because of some of these same social factors that make individuals unhealthy, also hold children back from being able to excel in school. So there are a lot of different community partners who are interested in seeing something like this come to fruition. Passport Health Plan really was one of those other key leaders in the community who'd been looking at a way to do this not only for themselves but for others. And so I would love Scott to give a little bit more of that overview of why you believe this was something that was necessary not only for Passport but also for the community. Did you turn it off? Oh, she did. There you go.
Hello, hello. All right. Nothing like taking your mind off of the question when you can't fix your microphone. When you think about, so when Passport thinks about health outcomes and improving care, it's hard to believe, but only 10% of the determinant of that outcome is based on genes and biology. 10% of that outcome, is the other, 70, 80, 90% is based on social, economic, environmental factors. And Passport recognized that 1 in 3 Kentuckians are Medicaid consumers, vulnerable population, $8 billion of Commonwealth dollars are spent on Medicaid health benefits. That's not including the federal dollars. And Passport had been focused on really trying to find ways to break down the social barriers and ensure that the needs of individuals could be met. And so looked at creating this partnership with United Community and the platform with Unite Us to begin to leverage and extend more seamless navigation into community resources. And so we had been set up with a care management team with nurses, social workers, community health workers, care coordinators. It's kind of like you have the carpenter, but do you have the tools? And here was a tool that came about with this platform, this shared database. Beyond just the database, it is a group of individuals who have come together and recognized the power in listing all of these community resources, and almost like an Uber application, being able to really identify which community resources are available, and we can now refer individuals into that community resource. So you think about social determinants of health. We've done some studies and have found that, number one, for our members, 300,000 across the Commonwealth, has been a need for food, a need for employment, a need for housing. And if you can't get those basic needs, it's really hard to take care of your health care. And so really looked at the opportunity to partner with this group and to help individuals in the Louisville area. We've done this kind of work before with having a database of community resources, but the trick here is now having a community that's partnering and leveraging and buying into this as the platform. And now we know who's available, and we can see that member or or that citizen, that community member, getting the resources they need with a closed loop to know that they got that food, or they know they got that housing, or they know they got whatever those resources are in order to break down the barrier to be able to get healthier.
That's awesome. And I know, Barbara, you were there for when we announced bringing this to the community. And having worked in your field for so long, shared that this was something you've been waiting for quite a while. And Barbara is one of our super users of the system that has been up since April. And so if you would just share, how you're seeing that work, and in particular for the aging care population that you are working with, because I think when we were initially thinking about it, we were really thinking about our most vulnerable, but we recognized that whether you fall into a traditional category of what folks think about coming to our nonprofit partners, or are individuals who are seeking care for your aging parents, this really is a platform that has a lot of different uses.
So yes, I have been doing this for a very, very long time. And when I first began to work in the field of human service, social services, I worked with persons with disabilities, particularly those with intellectual disabilities in another state, but nevertheless, the issues are the same. And from that point, about 40 years ago until now, one of the biggest needs that we have is knowing where the resources are. We often have a group of professionals and community-based organizations that we're very aware of, but in a city like Louisville particularly, where we're very resource rich, we don't always know how to access those programs and services, or how to connect to the agency or the entity. My agency serves as the Aging and Disability Resource Center for a 7-county region, and our primary role within that resource center is to help people to connect to resources. Obviously, my staff have a variety of skill sets that they utilize, including Google, to try to figure out where these resources are. The other side of the coin is that many individuals in our community call us, and they need to connect to resources. Not only are we looking for resources for people that we serve, but individuals from the community, regardless of age, call us looking for resources, and we try to connect them to those resources. Obviously, United Community, I called it the resource directory on steroids. when I learned about it, when I began to understand what it could do, and we've not reached that potential yet, but when I learned what it could do, I understood that this is what we've been looking for decades, is a technological solution to community-based organizations as well as healthcare, et cetera, coming together in a database, in a system where there is seamless connection, connecting not each other, meaning the community-based organization, but those individuals who need a service to that service that they need. And the other part of this equation is the fact that often we were successful in doing that, but many times we don't know what happens after the fact. We don't know whether that person was served, whether the agency was able to accept them, whether they was eligible for the service that we referred them to. And often because we're all so busy in our communities, we didn't always call that entity back, that referral agency. We didn't always call them back and say, hey, we were able to serve so-and-so, not because we didn't want to, but often we didn't have the time. Staff, obviously, in many of these community-based organizations are, they work very, very hard and don't have a lot of time in their day to do even the things that they currently do. So this particular system was a solution for that as well. You can actually look in the system and you can know what happened to that person that you referred. One of the areas that we work in very specifically is caregivers, for example, and that's actually the highest referral area currently coming to us at KIPTA. And many times caregivers, I don't know if any of you've been a caregiver. I've been a caregiver, I'm currently a caregiver. Many times caregivers find themselves in situations where they just don't know what to do next. If you've ever served a caregiver in your spaces, you probably know that they're often frustrated and frazzled and they just need someone to connect the dots. Well, I believe all of the individuals who were referred to us thus far in United Community, we've been able to connect them to the services and the resources and have been able to validate that through this particular system. From my perspective, that's a win-win, especially knowing how challenging it is for caregivers to find those services and resources that they need, because I've been there. I've been one of those caregivers working in the field, trying to figure out how to connect my loved one to the resources. And I could talk about this all day, but I won't. I'll stop there.
Ooh, there we go, came on. And just, thinking about that referral directory, we as United Way have been investing in a resource called 211 in our community for over 12 years. And that is that resource directory, but just as Barbara said, we never had the insight to know that when we were giving someone information about the Healing Place or Center for Women and Families or Centerstone, that organization had the capacity at that moment to actually help that individual, to give them a bed, to give them a space, or that they qualified for the services that they had. And this allows for that sort of validated referral. And that was one of the things we really appreciated about Unite Us, Stacey, was the clarification that this is really people-to-people connection. The technology is just, the facilitator of that, but we're really about creating these human networks. And so I would love for you to share a little bit more about the genesis behind that for Unite Us and how it's being used in other communities and maybe what makes it unique here in Louisville.
Sure. Okay. Can you guys hear me? Okay, there we go. So we definitely, the sort of early days of Unite Us started in the veteran and military space. And I think this problem that we're talking about has surfaced in several different types of communities across the country. It's not exclusive to healthcare. This is a humanity problem that we're dealing with. And people need, when they represent with one issue, often have co-occurring needs. And if you've been a caregiver, like I know many of you probably have as well, you know that in order to really provide the appropriate support, you need access to the resources and you need to know what's available. And those resources need to know about each other as well. And so that when somebody does come into a homeless shelter, but they represent with additional needs, that they can then be referred to another service and that we can treat the whole person. So when we started back in about 7 or 8 years ago in the veteran and military space, it was about helping veterans find access to resources and help them on their journey to sort of re-entry back into civilian life, and for veteran families that needed help. And what we realized over time is that this is not just a veteran problem. It's not just a aging population problem. It's everybody and anybody who's in a vulnerable population that needs access to help. And even if you're not in a vulnerable population, if you've ever tried to navigate our healthcare system for somebody who is sick and needs additional resources, it's really hard. And so we recognized at Unite Us that we need a technology platform that solves this problem, that goes beyond just a directory, that allows for people to see outcomes. We also needed to solve this problem around being in the community, really engaging with the community-based organizations and understanding what they need to get in a referral so that they can have a more efficient process in supporting the patient and that they know what services are available to them. And when you sort of think about where this industry is headed, I think that a lot of legislation has been passed over the last 10 years. We've moved from fee-for-service into value-based care. And right now, everybody's trying to understand, what is the ROI on social determinants? How are we going to prove this business case? Who's going to pay for this? Where's the sustainable model going to be in long-term funding? And you have what I think is the beginning of from the our ability to track these outcomes, and there's value to it in being able to see what's happening, but the business case is now sort of coming to light around how many people actually are we helping? What services are they using? What community-based organizations are being accessed the most and are tapped? Maybe we should put more resources there. So it's a window into a world that has always existed, and now we can just begin to really adjust and adapt the people part of it. So the technology is really important, but the people part of how we do a referral network in a community and manage community resources is also very important.
That's great. And I know, Scott, would you speak a little bit too to the ROI, the sustainability, the funding? It's one thing in our community that we've been able to launch this, and Passport was one of those early investors. You also have at your table this pamphlet that talks on the back about who else helped sort of support the innovation capital to get this platform into our community. But we know that we want to be able to have this persist much longer than philanthropic capacity can do. So,
sure, talk about some of the statistics, some of the ROI, some of the studies we've done at Passport that I think can go even further as we leverage this new program, a new product. So at Passport, we, a couple of years ago, went on a transformational journey to really look at our clinical strategy and how we go about coordinating care more effectively. And so we began using a lot of what we learned earlier today around AI and machine learning and predictive modeling to look at claims and lab and pharmacy data and other things that really help us understand and predict who could get sick, who could have an event. Over the last year, we now have included what we're calling our social needs index. And so now we are able to actually tell who has the greatest need for community resources, not just clinical needs. And so we're layering that into our predictive modeling to say, hey, this individual lives in a community that has high poverty, poor education, not a safe neighborhood. There are statistics that are public that now we layer into our predictive modeling, and we can identify and target who we think our care coordinators and our community health workers need to go to. And to your point, we had used 211, we had used other databases to really be able to understand what's available. In some of our studies, we found that of those that we targeted, and remember the ones that are targeted are the ones that need the care, so it's a bit skewed, but the ones that we reached out to, they self-reported, 84% of them had a need, a social need. 54% had at least 2 or more social needs. And what we found after 6-month review and a look back of medical costs is if we leveraged our community care connectors, our community health workers, our nurses to help coordinate that care and get what they needed, and had a database to connect them to community resources, we saw a 23% reduction in cost. And that's sort of in line with some of what you see national studies where I think it was 24% increase in readmissions for individuals who have lower poverty level. So it's kind of all sort of aligning with what you see nationally, with what our experiences have been. Now, that didn't include the closed loop model. That didn't include this kind of a community, United Community and Unite Us model where you can actually see what resources are available, whether the person got those resources. So I think that can leverage those kinds of numbers even more greatly. I mean, that 23% reduction that we saw in our own study before using this was something like $390 per member per month reduction. That's a big number that allows us to be good stewards of Commonwealth's dollars and be able to reduce costs and get people the care they need. And I'm excited about the Unite Us platform and United Community because we can now take the data that we know, the predictive modeling, and the individuals that can coordinate care, and now take a platform that many more community resources are beginning to leverage to get individuals the care that they need.
Thank you. And I know in terms of that leveraging this system, you know, Barbara, one of the things that you touched on was the way in which you and your peers worked in trying to connect people and searching that directory. And that takes a lot of time. And not also knowing whether or not they got there and having to follow up and stuff. So if you could speak to a bit of how this system, you know, you're using it differently today and where you see some of the potential. You mentioned there's still some untapped potential there of how you, others, like you can use this to be able to really help those you're trying to serve.
Yeah, sure. I wrote down 4 words earlier today as I was continuing to contemplate this discussion, and the 4 words were connectivity, access, data, and knowledge. And just to respond to your question, I want to focus on knowledge. We have learned by utilizing United Communities in this short time frame that it has given my staff additional knowledge about what is available as well. So, you know, just thinking about potential and learning and understanding, you know, it is their job to know what resources are out there. And I believe that the more entities, the more community-based organizations, et cetera, that come into the United Community platform, the more all of us are going to be able to understand not only what is available, but how we can access it. And that's powerful because, again, using the antiquated systems, we're not able to do that. We don't always know that. The other, I believe, really important and powerful potential of United Communities is, yes, being able to close that loop, but also for those individuals that we do touch and we're not able to close the loop, we also have that knowledge. We have that information. We know why. My staff are trained to document, and many other organizations are in this realm as well, and they will identify why they couldn't close the loop, whether the entity that they referred the person to didn't have enough resources to serve them, which is possible, and that may occur at our agency as well. We may receive a referral for our home care program, for example. That program provides in-home services, case management, and assessment to individuals who need it. Well, it's a state-funded program, and we have a wait list. So although we may receive that referral, we may not always be able to serve them right away. They may go on the wait list. That's documented. That is information, that's data, actually, that can be utilized to help us understand, I believe you said earlier, or maybe you, where the need is, where we need to put more resources. So, you know, again, the potential and the possibilities with this particular system with United Communities is endless. I'm probably going to be able to dream and think of other ways that we'll be able to use it and garner information and knowledge to help us to do what we do every day better, and that is to serve the citizens of this community and to help them to access the programs and services they need and to live where they choose to live for as long as they possibly can.
Well, and we can dream, but we can also learn from others who are maybe a few steps ahead of us, because I know that there are communities and markets that Unitas is working with. I think of North Carolina and some others that have been at this a little bit longer and are doing some really interesting and innovative things in this space. Stacey, if you could speak to that.
Yeah, I'd be happy to. So, you know, there are definitely some skeptics still around what to do about social determinants of health, and then there are some organizations that believe fundamentally that you need to have a home for someone, that they need to not be hungry, and that they need to not be lonely in order to actually treat them from a clinical perspective. And they look at it comprehensively, and they believe that to their core. And a couple of examples that come to mind about, you know, those organizations that just fundamentally get that connection and are going at scale are the state of North Carolina, where they're rolling Unite Us as a referral platform. They're branded NC Care 360 out to all 100 counties across the state. What's interesting about their approach is it's a big state with, you know, over 17 million people, I believe, and they have rural areas where there may not be access to community-based organizations in the same way that there are in urban areas. And so they're taking this concept of, you know, no wrong door, give everybody a path in to get support and help. So religious organizations, churches, barbershops are on the network. And it really is trying to connect the people to the services that are available to them. And the way they're thinking about it, which I love, is they're thinking about it from the person-centered perspective. Where do you go to get help? Where do you go to ask someone if they can refer you to somewhere? That's the perspective, and they're rolling it out across the state, which is really exciting. Another example is Kaiser Permanente, and KP is rolling this out. They made a big decision to roll this out. They announced it in the spring to all 12.3 million members across 10 states. That's going to reach 68 million Americans that will have access to a community referral network in a way that we just haven't seen at that kind of scale. And their approach to this from a business case perspective is, you know, they're looking at the impact in quality of life. They're looking at the impact in total cost of care reduction. And they, I think, fundamentally believe they're going to improve their member experience. And so in both of those situations, the funding models that they're using are very different. And I still think that is going to play out over the next year, or especially over 2020. But as this space evolves, and it's moving really fast because you have these sort of organizations that are doing this at scale, and then everybody's sort of watching to see, well, how do we fund this going forward? How do we, you know, create sustainable models to fund big scale deployments like this? And I think that it's going to be partially a regulatory question, and potentially at the state level, potentially at the federal level. But I think everybody's trying to recognizes most organizations that this is coming, and now we're trying to figure out, you know, what is the best path forward to fund it broadly across the country.
And really, I think it's a public-private partnership in some of those elements. And I know in North Carolina, you were talking about the block grant that they had.
Yeah, so in North Carolina, that is a public-private partnership. They have a block grant from the federal government, not for the referral network, but they are they're testing the reimbursement of social determinants of health, and they're using that funding for testing the efficacy of providing people with services. So for example, if somebody comes into, the ED with a child with asthma and they keep coming back every month, is it more expensive to pay for the ED visit, or is it better to replace the moldy rug that's in their room that's causing the return visits every month? And so what they're coming up with in North Carolina is, let's try and address the drivers and potentially the root cause, if we can, to prevent some of the cost in the model.
Thank you. And when you think about the theme of this conference really being about aging care, and we said at the beginning, and I love AARP with the sort of idea of the ageless, and that really developing systems that can meet any age really do help all, even if you've got a user group that's kind of 50 plus that they're talking about. But when you think about that population in particular and trying to think through what Passport has been leaning into doing, Scott, some more reflections on how, with the theme of this conference, United Community or the work of Passport in general is really looking to be innovative.
Yeah, so we're serving over 300,000 Medicaid lives and another few thousand Medicare Advantage lives that are dual, so they have Medicaid and Medicare. And so there's this absolute crossover with the aging and the disabled. I met with one of our social workers, Rhonda, yesterday, and I said I was going to be here, and I said, tell me about how we are using the application, tell me about an experience that you had. And she was sharing that, in the past, we've had databases, but in this particular case, now we have community organizations that are using it, putting data in and understanding it. The story she told me was a woman, and this sort of gets to the aging, disabled, how are we able to help these individuals, and why is this good for them? She talked about one of our members who was living with her boyfriend, was trying to get her disability benefit. They were struggling for resources. She didn't have an ID. She wasn't able to get the disability benefit. She didn't have a state ID, and they didn't have the resources. Rhonda went into the system and found Shively Area Ministries, who was able to offer the $460 in rent assistance, so she didn't get evicted. And that went to her pretty quickly. She saw it in the system happening. Rhonda did. She saw on that platform that it was occurring. And so the lady received her funds, was able to prevent an eviction, keep the family together. Our community social worker then helped this lady get her state ID so she could get her disability benefits, and going forward she should be able to work through the system and have the resources she needs, to stay in her apartment and to get the benefits that she needs in order to continue forward. To your point, that probably prevented some significant costs in the system, and it certainly improved her quality of life, and isn't that why everybody in this room is here today, is to do just that? And so I think whether it's the disabled population aging, this is the kind of tool that can make an impact.
And that was definitely something for those that were in the room this morning for the keynote. I remember, William Fleming talking about the need to really gain those insights from in-home care workers or social workers or nurses who have a little bit more data that can also feed back to the clinical side of what's going on in the home and how can we address some of these other issues. You mentioned the rent assistance, and we were talking earlier about some of the insights, I think, Stacy, that you picked up on in looking at our data about the utility side of things. And if you could just speak to that.
Yeah, I mean, it's interesting. I think this network and across the country, what you see in terms of what's happening in your community, based on where are people getting referred to. So it's a window into what's happening and where people's needs are. I think in what's been interesting about looking at the United Community Network is that you can see a number of people coming in for utilities assistance. So there are people who are on this social determinants of health journey, and they may not have power. And if they don't have power, it's likely that there'll be follow-on challenges, and that this will then spiral, and that there will be an impact to their health. And if we can get ahead of that upstream and help them get the assistance they need, not just with getting the power back on, but also maybe it's perhaps they need employment help and coaching. And so what we often find in these situations is that you're sending a referral for utilities assistance, but also for other assistance related to the situation that they're in.
Yeah, and I think what was interesting from what we've also identified in our network is that oftentimes the utility assistance that an individual can receive from one organization doesn't cover the full bill, but to other organizations to piecemeal the assistance to get the bill covered. And so how do we change the way we make that accessible for the full cost of the need to individuals so they don't have to go to 3 or 4 different organizations? And so how do we get more effective as a community in doing what we're trying to do anyways, but we're making folks jump through multiple hoops to do that? And I'm sure this population can understand, if you don't have power, what does that mean for your health, as you shared? I know we're getting close to the end of our time, and we are standing between you and happy hour, which is probably the worst thing to stand between anybody with. But I want to open it up to the community, to the folks in this room. We've got about 10 or so minutes for questions. So what questions do you have? We haven't even scratched the surface on where we can go with all the data and insights from this, but yeah.
Let me just repeat that to make sure I understood. Okay. So you're... Yeah, so we talk about this, where we are with the Louisville network, we're at ground zero, which is the early stages, and we're building the infrastructure. What we're doing in North Carolina in that particular example is exactly that. But we're building that out with them now. It'll be the first of its kind in the country, but that is the idea, that is the path forward.
And I will say here locally, we started with what are the most critical needs that we have to be able to meet from that social, medical, education space, and then recognizing that there's kind of sort of these rings that go out from that, where we can start to add in private sector organizations that complement what we're trying to do from a social good standpoint, and that can really help accelerate some of that. So we'd love to follow up with more conversation on it.
Not to speak to the incentive piece, but just this notion of finding partners that can have a significant impact, and to build off of your North Carolina example. I mean, JCPS is also at the table here, and to be able to have worked through the data sharing issues, the privacy issues, to create a public-private partnership is really impactful right now. And so as we leverage that and we work through the early stages of the data and the early stages of partnering with the school systems to get the families the help they need, and then move to merchants and move to incentives, I mean, I think that's the next frontier of how this can really take off.
Was there another question in here? Over there, thank you, Susan.
we're learning so much in North Carolina. So we started out like very similar sort of situation in Louisville, where you start out slow, and then as you build up momentum, you bring on more community-based partners. We started out with 1 or 2 counties, then we moved it into 13 counties. Now we're onboarding 40 counties, and we're just able to create this increase in velocity. So each of the different community-based organizations have their own sort of workflows within how they want to receive and intake individuals seeking services. And when we provide them with additional information, when a referral comes through, we're basically capturing information that they've never really had in aggregate before. And so what you realize, or what they're seeing, there's a window of data here that the community-based organizations are now able to capture. And through that, they're finding, and through the analytics from what needs are, I think, to your point earlier, are not going met, have been really informative for us, particularly when you look at it by county, what type of service in a county, and all of that information going back into the state in terms of their thinking about where funding is going for resources, I think is going to be so impactful. So as I said, we're really in the early stages, and as we're ramping this up and now creating more velocity in the number of counties that we're onboarding, the information that we're learning from the intake forms, the information that we're learning from all of the reports and analytics. One of my favorite stories is, I think it was Guilford County. I don't know if you might know this, Brian. But the network just launched, and this woman came into a church to pray, and she was homeless. And someone at the church said, I have access to this new service. Let me see if we can help. And in our software, there's this Uber feature that you guys, I love the name you coined for it, that allows you to ping out a need for shelter, and whoever picks that person up, it recalls the other requests. So there isn't someone at the church calling 7 different homeless shelters to see if somebody has availability there. And it creates this efficiency to really help people. Because if we think about what we're all trying to accomplish by helping people that are in need, is to help take some of the friction out of the process that they're currently dealing with, to make it easy for them to navigate and get help, and for people to make it easy for people who are trying to help them to be able to successfully do so. And so she ends up getting access to housing, and it was one of the first referrals that went out on the network. Through the housing intake, they got her into employment services. And it's just such an incredible story of one of the beginning, of this journey in that state.
I love that. Yeah. Yeah, so I'll take a quick step on the first one and then share the microphone and have our panel respond. But I will say, on the capacity piece, especially coming from Metro United Way and seeing the needs in the human service space and knowing that we never have enough resources to meet all the needs, part of what the system is doing is making it transparent in a very validated way where all of these needs are across our community, and where, as we said before, needs are going unmet because of a supply-demand mismatch, right? We have over requests and demand for services, and we do not have the supply there. But for most of us, being in the human service space, especially in a nonprofit, we've not been able to invest in the technology and the data and the resources to also track that in a way that's really easy to report that back out to our community partners. It's often who can tell the best sad story and get the money for the support that they need in the community. And we struggle to really understand how many affordable housing units do we need. I mean, we had to commission this huge study with U of L to get to that space, and we probably still are trying to figure out how much of that is duplicative in terms of multiple folk, or one folk been on multiple lists. So I think this just makes it so much more clear for us to be able to tell our story as a human service space about what's really needed there. On the fraud side, I might turn it over to the panel to talk a little bit about that.
So I know Scott wants to add to this too, so I'll just be really quick about the software, just a couple of things. It's HIPAA compliant. The information about patient, especially in a vulnerable referral, is masked. So if they're getting referred to domestic violence, it doesn't, you can't see that, and others in the network can't see it. So there's a lot, when Teresa and Scott were talking about a lot of work that goes into getting this going, and all the security reviews, and within every organization, it has to be able to comply with that. And a lot of the software technology that we built was designed to address those, because you can't have a referral network and do so successfully if you can't have the transparency. So we were very intentional with that, and I'm happy to follow up with you in more detail about it, and pass it to Scott if you want to.
Yeah, I would. Your point's well taken. I think, obviously, certainly in the healthcare space, compliance is so critical as we look at this. I would point to the way this group is organized around governance, and the fact that they have done things like gotten grants from Robert Wood Johnson Foundation in order to work on privacy issues around data in particular, speaks volumes to the fact that they're thinking about these kinds of compliance issues and trying to find funding to think through it and address it. And it's so unique that health systems like Nemours is reaching out to Passport saying, hey, we're writing a paper with Mental Health America on how you even figured out the privacy issues and the data sharing. Can you tell us more about that? And so I think that just speaks to the fact that the team is all over trying to determine how you ensure compliance and governance in the system.
And also, just from a practical standpoint, being a user from a community-based organization, that knowledge, that information has to pass down to the users. And they do receive a pretty rigorous training. And one of the complaints of the users at my agency has to do with getting those permissions from the individual to share their information. And I do know that there have been a lot of discussion around that particular aspect, and some workarounds, and not necessarily workarounds, that's the wrong word, isn't it? But some strategies to help us to be able to do that better. So, my agency also have to follow HIPAA, and we are required to make sure that person's information is kept confidential, and that we get the proper permissions. So we're very, very sensitive in that space and in that area, and are really, really excited about implementing some of the new things that we've learned about the system to help us to be able to communicate better with the people who are calling to make sure that they feel that their information is going to be protected, that it's safe. On the capacity end, I can talk to you later about that too. That's a real issue, and I believe it's something that I've discussed here today, but also even earlier. But there's some good in what we're going to be able to ascertain from the system. That, for example, my network across the state, we advocate, we go to Frankfurt and we try to talk to the policymakers about the needs. I believe we'll be able to get data from the system that will help us to validate the fact that there aren't enough resources being provided, for example, to the home care program that I mentioned earlier, which is going to help to support our case. So, I believe this system can really it could either be the legislators and policymakers' best dream or worst nightmare. It just depends on which way you look at it.
So I know we're at the end of the session, although we also started a little bit later. So I might just see if there's one last question from the audience and then have closing comments from our panel. Nobody wants to be that last question who holds us up. Okay, so really, if there's any last remarks, I mean, I think we've had a really robust discussion and really painted a picture. And if anybody wants to learn more, again, you've got the information on their table. But Scott, anything you want to leave our room with at the end of this great day?
I think we've said a lot already. I think from our perspective, you can really leverage and scale a lot of the clinical strategies that are in the community where we're trying to help do care coordination, and you have to get at the social needs. You have to break down the barriers. There's only so many folks on the phone or only so many community health workers that we have to try to connect folks. So having enabling tools to create more seamless navigation with the community resources can be very powerful, and being able to collect the data and manage the capacity and know who's available and not double leverage or double utilize the resources that we have, the sparse resources that we have is critical. So I'm bullish on where this can go.
Yes, and I'll just add very briefly that we are using the United Communities, and we started out just with our Aging and Disability Resource Center, but we also have case managers, and we work in the community very intimately, one-on-one with individuals and families every day. So we're looking forward to expanding and getting more licenses for some of our other staff who can utilize this in a very, very real and beneficial way on behalf of the people we serve. So we're excited.
My remarks are to my fellow panelists. We are so proud of what you guys are doing in Louisville at Unite Us, and that you're blazing, this trail for this city. It's going to be so impactful. And I hope that you all embrace it and be a part of it. And if there's any chance that we can be helpful in getting you there, I would just really encourage it.
Oh.